I am
Dr.
here,
Ruth?
Kasibante. I am here.
Great,
Yes,
good to hear. Good. So our presenter today is Dr. Ruth Namazzi, as I've already said, and she's a pediatrician. She's a lecturer of pediatrics at Makerere University. She's also a pediatric hematologist, oncologist who works with the pediatric unit at Mulago Hospital. She's an investigator, and Ginger Hospital is proud of Dr. Namazzi because we are doing a lot of work with the organization where she's the chief executive, that's Global Health Uganda. The organization has done a lot of studies in sickle cell, part of which has led to policy changes in treatment, but also in the general programming for sickle cell. We cannot speak much about sickle cell because that will be the nitty-gritty of the study, but Busoga is the worst. The heat, let me use the word heat as if it's an infectious epidemic. But Busoga, the prevalence of sickle cell in the Busoga region is quite high and a bit worrying. The recent survey, which is actually old, that was around 2015, indicates that 1.3% of our people in Busoga are sickle cell, have sickle cell disease, and a carrier rate of around 13%. That's extremely high. So our government has done a lot to make sure that we improve service delivery in the area of sickle cell and reach to as many children as possible. Probably if it misses in Dr. Namazzi's presentation, probably we'll talk about what the programming areas towards sickle cell are looking like to them. But for today, the topic is comprehensive management of sickle cell disease using hydroxyurea. And I think we have the most capable person who is passionate about children with sickle cell and adults, I think, even if she's a pediatrician or even when she's a pediatrician, she has passion for sickle cell treatment, research, and training. I invite you, Dr. Ruth, to take on the podium. Oh, this is a virtual one. A virtual podium, and you deliver the presentation. I'm so glad that the chat has a number, the call has a number of people. So people are really waiting to listen from you. So you can take it from there. Thank you so much.
Thank you, Kasibante, for that kind introduction. And thank you, Busoga Health Forum, for inviting me. It's always a pleasure to speak at the Busoga Health Forum. And we are really happy for the partnership and also the work that Busoga Health Forum is doing. I hope you can hear me very well. Today, I'm going to talk about hydroxyurea. It's an area that I'm really passionate about for sickle cell disease because it's a game changer. My name is Ruth Namazzi, as already introduced. I work at Makerere University as a pediatrician, but also I specialized in childhood cancer and blood disorders. But my interest there is sickle cell disease. So we have seen this before. Sickle cell, I'm not going to talk about what sickle cell disease is, you probably know. We're going to focus today on hydroxyurea, and we want to give time for discussion at the end. But sickle cell disease is common and it's associated with very many complications. The treatment is in layers. Most of what we are doing currently is just symptomatic treatment of complications, including pain management, including penicillin prophylaxis. But really what we should be doing is to modify the disease early, and those are some of the disease-modifying treatments. The most common we know is hydroxyurea, which I'm going to talk about today. But the other modalities, including chronic blood transfusion, which I'll also talk about, and also other agents that are coming onto the market that I think we need to address. If you want to cure sickle cell disease, there are only two known treatments, bone marrow transplant and lately gene therapy. Those we shall get webinars later. Sickle cell disease has been common, but the development of drugs has been very slow. The first child or patient diagnosed with sickle cell disease was in 1910, but the first disease drug for sickle cell disease in the USA was only approved in 1998. So very, very many years before any treatment was approved for sickle cell disease. So even what we're seeing, like Kasibante was saying, that we're seeing a lot of sickle cell disease, it's because of some of the delays that have been in the approval for medications for sickle cell disease. So the first approved drug was Hydroxyurea in 1998 in the USA. And over the years, over the last 10 years, there's been several new drugs, including Voxelotor, we shall talk about it later, L-glutamine, and then crenalizumab, which also we shall just briefly talk about because today we're talking about sickle cell disease. So you can see how slow the process has been. But what is hydroxyurea? Hydroxyurea really is an hydroxylated analog of urea, and it was first synthesized in 1869. So this is not a new drug. We've been having it a lot. It was first studied in animals in 1928 for cancer. And since then, it was approved for cancers, for treatment of cancer from 1928. It was first tested in human beings in 1984, and like I said, it was approved for use in 1998. How does it work? Because most people talk about it's an anti-cancer drug. Why are we giving it? Really, in the doses that we are giving it, what it does is that it inhibits synthesis of red cells. And in that way, it stops the production of sickle red cells. This stoppage, which is transient, it causes the body to react, what we call stress hematopoiesis. And instead of producing hemoglobin S, which causes sickle cell disease, the body instead produces hemoglobin F, which does not sickle, which is very good. And because it also causes bone marrow suppression, it also reduces on the number of white blood cells in the blood, which is important. There is spontaneous recovery of the enzyme, such that these effects are actually transient, such that if you stop the drug, I'm not sure what is going on with my screen. If you stop the drug, then everything goes back to normal. It's like those side effects that people talk about for hydroxy actually goes back to normal. What is really important about sickle cell disease and hydroxyurea is that the drug does not actually develop resistance. Most of you are going to hear patients asking, if I don't take my drug, would it stop working? No, you don't actually develop resistance in a way that you develop resistance to antibiotics. That's a good thing about about hydroxyurea in sickle cell disease. And we don't see people stopping to respond to it. Once you start responding to it, you continue to respond to it, which is very good. So what does hydroxyurea do? Okay, we know that the problem of sickle cell disease is sickle hemoglobin. So what it does is that it increases the production of hemoglobin F. Hemoglobin F is the type of hemoglobin that we have when we are still in utero, babies in utero, which does not sickle, okay? And in increasing the production of hemoglobin S, it reduces the hemoglobin S production. Therefore, it reduces the amount of sickling. And if you reduce the amount of sickling, then that means you actually reduce almost everything else that follows. It also makes the red cell more round, okay? And reduces the red cell damage, membrane damage, which causes anemia. It causes decreased hemolysis, which causes anemia. Like I said, it causes bone marrow suppression, so it reduces the amount of neutrophils. In sickle cell disease, which is a chronic inflammatory condition, you find that you have a very raised white cell count, which is bad. So we want that count to come down, okay? It also increases hemoglobin synthesis because it's reducing on the sickling. It reduces vasoconstriction because it increases nitric oxide, as we shall see later. One of the problems of sickle cell disease is vasoconstriction and narrowing of the vessels. So hydroxyurea actually reduces the vasoconstriction, which is very good. So that means it helps the blood vessels to be much more open. It decreases thrombosis. It decreases the particles, platelets from adhering to the endothelium. So reduces actually the vasculopathy that leads to stroke in children and adults with sickle cell disease. So in a nutshell, how does hydroxyurea work? It increases hemoglobin F production and reduces cell counts. It reduces the RBC adhesion to the endothelium and the platelet adherent to the endothelium, so it protects the endothelium. It allows the red cells to become more round and therefore move much easier through the red cells. and to the blood vessels, and also increases nitric acid production. So it opens up the blood vessels, which we want for sickle cell disease. So that is just how hydroxyurea works. What is the drug like? Why do we want to take it orally? It is rapidly absorbed after oral intake. It takes about 1 to 4 hours, and that is why we want our patients to be taking it at a particular time and not to worry about, vomiting after 1 or 2 hours, because it's rapidly absorbed. There's no data to suggest that there's any interaction with food, and so you can take it with anything. This question usually comes up for children who don't swallow a capsule. Can we put it in water? Yes. Can we put it in milk? Yes. Can we put it in porridge? Yes. There is no data to suggest that it interacts with food. It concentrates a lot in the leukocytes, so it has a lot of effect on the leukocytes. So it causes a lot of reduction in the leukocyte count, but also changes in the red blood cells. It is metabolized in the liver, and so we want a normal liver function, and is also excreted directly by the kidney. We don't see a lot of kidney damage, but we need to know this as we are giving children and adults hydroxyurea. So clinically, what do we see when we give children and adults with sickle cell disease hydroxyurea? We see marked reduction in pain episode by almost 50%. We see a reduced need for blood transfusion. In our studies, as Kasibante has told you, we are following up children for all they don't come back to hospital for hospitalization. If they come back for mild illnesses, which is very good. And when you give hydroxyurea earlier on in infants, later on I'm going to tell you that we want to start very early as 9 months, it actually preserves spleen function. We all know that children with sickle cell disease are at risk of severe infections because of hyposplenism, because they lose the spleen very early. But when you give hydroxyurea, it actually preserves that function and also improves growth and development. We have seen children who are on hydroxyurea grow much, much better and taller than children who are not on hydroxyurea. So hydroxyurea has multiple benefits in children and adolescents, and even in adults with sickle cell disease. So, like I said, there's been a lot of research. The first test studies were done in 1984 in humans. And since then, multiple studies have been done over the last 30 to 40 years. The problem is that most of these studies were done outside of Africa, yet Africa has the highest burden of sickle cell disease. The first studies in sickle cell disease started around 2015, some in Nigeria, and then mainly in Uganda, the No Harm trial, which allowed us and showed us that hydroxyurea is actually safe. So we are talking about a drug that has been researched for almost 40 years, and its safety profile has been proven. These are studies that were done in Uganda. The first study was actually done in Mulago National Referral Hospital. You can see some of these people are very familiar, Opoka, Kasidie. It was done, and the worry initially was that hydroxyurea may increase the risk of malaria, and it was not safe because I said, it does reduce on some of the blood count. So people were wondering that if you introduce hydroxyurea in Africa, where the number of infections are very high, number of infections like malaria are very high, won't you be causing these children harm? And so that No Harm study was done, started in 2012, 2013, and ended in 2017. And the results showed that actually there was no increased risk of malaria. In fact, hydroxyurea reduced the risk of malaria by almost 50%. Another study was done in Africa, in 4 countries, in Uganda, in Kenya, in Malawi, and in DRC, again, to validate the results that the No Harm trial had done, because No Harm was only in one country. And it showed the same thing, that actually hydroxyurea is safe and it is effective in children in Africa, and actually reduces on the risk of malaria. And so these studies, the Ministry of Health, especially in Uganda and the rest of Africa, adopted the use of hydroxyurea in children with sickle cell disease and approved it for its use. So therefore, with that, what did the Ministry of Health come to? They decided to endorse the drug, but start with indications for the use of hydroxyurea. So according to the Ministry of Health guidelines, you give hydroxyurea to children who have a painful crisis, which are frequent, stroke or history of stroke, abdominal TCD velocities greater than 200 centimeters, low baseline hemoglobin, 6 grams, less than 6 grams per deciliter, a history of or admission for acute chest syndrome. And these are common complications in children that you see. So it's really almost all children with sickle cell disease should be given a hydroxyurea. What are the contraindications? Pregnancy, we don't have any safety data about hydroxyurea and pregnancy. So we don't give it in people who are pregnant or those who want to get pregnant, or those who are sexually active and don't want to, use contraception. So we don't know the teratogenic effect of hydroxyurea on an unborn child. There's some studies that are starting up, but those are starting in mice, and then they'll move to monkeys. And if the regulatory approvals bodies allow, maybe to humans. It's really hard to study drugs in humans. Don't give it in active liver disease. You will see some children who have yellow eyes. Active liver disease, don't give it. If there's hypersensitivity to hydroxyurea, some children, a few, less than 1%, will come to you and say that, when they get hydroxyurea, they swell or they itch. Please don't give it to them. And also don't give hydroxyurea to people who are not compliant. Okay, so there are patients who you give hydroxyurea and they're not going to be compliant. You're wasting the drug. Keep it for people who are compliant. But for us, we are saying that don't wait for the complications to start. We are saying that give hydroxyurea to all children who are older than 9 months, okay? Studies that were done in the US and also in the rest of Africa began at the age of 9 months. Why 9 months? Usually children with sickle cell disease are protected up until the age of 6 months. The hemoglobin F levels in children about up to 6 months are high. So most of them are not symptomatic, but they start to show symptoms from 6 months onwards. So we are saying as soon as they're 9 months and they're more than 5 kilograms, please give them hydroxyurea. Do not wait for them to get a stroke. Do not wait for them to get acute chest syndrome, because when they get those complications, sometimes they die or some of the effects are irreversible. If a child gets a stroke, those effects are irreversible. So please do not wait for complications. In your areas, wherever you're working, you have a child with sickle cell disease, you have counseled the parents and they're willing to adhere to the hydroxyurea, offer it to them. So how do you start? Of course, you want to do some baseline investigations. First, get a complete blood count with differentials if you're able to do it. And a reticulocyte count. These days, CBC machines have automated reticulocyte counts. Please get it because it's going to help you to monitor the response. If you can, at baseline, do a quantitative hemoglobin electrophoresis. This one helps you to know how much hemoglobin F you have at the beginning, how much hemoglobin S you have at the beginning. Our aim for hydroxyurea is to raise the hemoglobin F while reducing the hemoglobin S. So it will help you to monitor the response. You want to do a baseline creatinine and urea. This should be within the normal range, okay, as much as possible, because hydroxyurea is excreted in the kidney. The liver function, usually in children with sickle cell disease, they have a bit of deranged liver enzymes because of ongoing hemolysis, but these enzymes shouldn't be more than 2 times the upper limit. So please don't withhold hydroxyurea because of a slightly raised AST or ALT. It shouldn't be above. As long as it's not above 2 times the upper limit, you can actually start hydroxyurea. So do a complete history, understand your patient, how many painful crises have they had in the last year, what are they like, what is their physical exam like, do they have a spleen? That is important, because sometimes when a child has a spleen, their response to hydroxyurea may not be as good. They burst, because with hydroxyurea, those should actually be reversed, okay? Discuss, please talk to the mother and the father or whoever has brought the patient about what hydroxyurea is. Don't tell them it's a cure, because it's not actually a cure. Tell them about the rationale, why you're giving hydroxyurea. Tell them this information we're giving to you today, and tell them about the potential side effects of hydroxyurea, okay, such that they can understand when something happens. Document that the family agrees to have regular clinic monitoring. If you're seeing a child who comes to your clinic once in 2 years, okay, that one is going to be a difficult child to monitor. Please document that they agree to have regular clinic monitoring, but also educate them about the importance of coming to the clinic regularly. Document the diagnosis of sickle cell disease. We have seen children in who have been in a sickle cell clinic and they've been told they have sickle cell disease only to do the HB electrophoresis, and it's negative. Okay, so first make sure that this child that you're giving hydroxyurea has sickle cell disease. So for you to start hydroxyurea, okay, the neutrophil count, absolute, not the percentage, should be more than 1,500 or 1.5 to the power 9, okay? The platelet count should be more than 100,000, okay? And the ALT, or the liver function, ALT, which is a liver enzyme, should be less than 2 times the upper limit and should have a normal creatinine, okay? So this is important as you're starting your hydroxyurea, okay? For children, we begin at 20 milligrams per kilo per day. For adults, we begin at 15 milligrams per kilo per day. Our guideline is that you do a complete blood count every month for the first 3 months. The reason for this is you want to get that the child is being adherent to, that you're not getting any acute complications, okay? After that, and after you have established a good adherence to the hydroxyurea, you can do your CBC every 3 months. And when you're stable on a good dose, you know, we're going to talk about the doses, okay? Then you can actually space that out every 4 months. And for some really adherent and very stable patients, we're actually now switching out to 6 months. So the monitoring is becoming less and less frequent as we get better knowledge and understanding of how hydroxyurea works. The monitoring really is for toxicity, okay? The toxicities, we shall talk about them. A reduced neutrophil count of less than 1.5, a reduced platelet count of less than 80,000. Those are the toxicities that we're talking about. And of course, sometimes some liver and renal toxicities. But we're also monitoring for clinical response. If a child used to have painful crises 5 times in a year, with hydroxyurea, those should reduce by 50%. So maybe you should have 2 or even 1 or even 0 during the year. If there's no clinical response, think about the dose, think about adherence. Also, we want to have a laboratory response, okay? We are expecting that the hemoglobin level is going to go up. We're expecting that the MCV is going to go up. We're expecting that the neutrophil count is going to go down, okay? So look at that laboratory response. And if there is no response, try to understand why. Is it because this person is not adhering? Is it because there's a existing other illness, like maybe iron deficiency? So you need to explain the lack of laboratory response, okay? We start at 20 milligrams per kilo per day, but we don't stop there, okay? We try to change the dose depending on, first of all, the weight, but also if there is no response. If, for example, you have a child who is at a high risk of stroke, okay, they have an abnormal TCD, or their TCD becomes abnormal while on hydroxyurea, we escalate the dose. If the child has a stroke, we escalate the dose. If the child's neutrophil count persistently remains above 6,000, we escalate the dose. And for those children who don't have a clinical response, they're on hydroxyurea, but they still be coming to hospital, we escalate that dose. How do we escalate? We escalate the dose by 5 milligrams per kilo per day every 6 to 8 weeks. Please note this, we don't escalate the dose every month, we escalate every 2 months because this is an anti-cancer drug, it's toxic, okay? So you don't over-escalate, don't quickly escalate. So every 6 to 8 weeks, and by only 5 milligrams. I've seen people escalating the dose from 20 to 30. No, escalate from 20 to 25, 25 to 30, and the dose, a maximum dose really is about 30. By that time, you have a response. There are very few children who go up to 35, okay? And then you monitor the liver and renal function only annually. So you don't need to keep doing liver function every time we come. I've seen people saying, oh, you need to do LDH. No. You don't need to do those things. You only do them once, okay? So what are the toxicities? I've already talked about them. There's transient, okay? Most common is neutropenia. The neutrophil count goes below 1.5, you hold hydroxyurea, okay? You can also have anemia, hemoglobin level going less than 6, and also thrombocytopenia, platelet count going less than 80,000. There's some mild renal toxicities that have been reported, and then some skin changes, about 10%. They'll come and tell you some nail changes. Those are reported, those are really mild. And also some nausea and vomiting. I have several patients who say, you know, when I take a hydroxyurea, I have nausea, okay? This, we tell them you take it at night, okay? Such that when it's peaking at 1 to 4 hours, the person is sleeping, okay? What is dose escalation? Why do we say we start at 20 and then go up? We know that the higher dose of hydroxyurea is actually better. Studies again were done in Uganda here, whereby they compared keeping the children at a fixed dose of 20 milligrams per kilo per day versus escalating it to as much as it can go up to 35 milligrams per kilo per day. And first of all, it was found that it is safe. okay? It didn't have any more additional side effects, but it had better clinical and laboratory benefits. If you look at these graphs, the blue is for a dose which was escalated versus the green at the fixed dose. They're both good, but you see that you have higher hemoglobin levels when you escalate the dose. Also, look at how much the fetal hemoglobin is, okay? When a child has a fetal hemoglobin about 30%, you're almost like a carrier. The child is almost asymptomatic. That is what we're actually aiming for. We are aiming for fetal hemoglobin of about 30% up there, okay? And then compared to this on a fixed dose. So the higher doses actually give you a better response. Also, they give you a lower neutrophil count. We don't want anything less than 1.5. So at these higher doses still, they didn't actually go less than 1.5, but actually they're more suppressed. When you have so many neutrophils in the blood and you have sickle cell disease, it actually causes viscosity and can give you a high risk of stroke. Same thing for reticulocytes. You don't want so many red cells in the blood, which are young and are not doing anything. So still at the dose which was escalated, you find that the reticulocytes actually are lower than at a fixed dose. So laboratory-wise, you have better benefit, but also clinically, you actually have better benefit, okay? So what is a dose that we call MTD, which is called the maximum tolerated dose? It's a dose when you don't have any toxicities and you're aiming to have a neutrophil count of 2,000 to 4,000. So when you're monitoring your child or your adult with sickle cell disease, look at the neutrophil count. Usually they start with 10, then it starts coming down, and then you keep playing around the dose until you get a neutrophil count of between 2,000 and 4,000, okay? Whenever you're escalating, please monitor the complete blood count, because sometimes people's doses are too high as you're escalating. Someone's maximum tolerated dose might be 23. So if you overgo quickly to 27, you might actually get a dose toxicity, okay? I've already talked about this monitoring. Check the MCV, it should be going up. Sometimes it goes up to 120, that is very good. The white blood cell count, the neutrophil count, the absolute reticulocyte count if you have, these ones should be going down. The hemoglobin level, however, should be going up and the MCV should be increasing. It's important to weigh the patient, especially if it's a child, because children's weights change. The most common cause of low dosing of hydroxyurea is not checking the weight. So you can set at a good dose of 20 milligrams per kilo per day for a child who is 10 kilograms. But 2 years later, the child is 15 kilos, okay? You need to check the dose and change it, okay? If there's a toxicity, that is if the neutrophil count is less than 1,500, the hemoglobin is less than 6, the neutrophil count is less than 80,000, or the platelets are less than 80,000, please stop the hydroxyurea. That is a toxicity which can be dangerous to the patient, okay? What do? Hold it for a week, okay? And every week, monitor the CBC. Usually after 1 week, those counts have actually recovered. Sometimes people will take up to 2 weeks, but most people recover after a week because, like I mentioned earlier, the effects of hydroxyurea are transient, okay? They are not permanent, okay? Once you withdraw the drug, the effects actually go away. And that is why it's important for us to adhere, because if you don't have, if you're not adhering, then the effects have gone away. After you've withheld hydroxyurea for toxicity, when you're restarting the dose, when the counts recover, you restart the dose at a lower dose, reduce the dose that caused the toxicity by 5. So for example, if a child was 20 milligrams per kilo per day and they got a toxicity, when you're restarting, start at 15 milligrams per kilo per day, and then you can escalate slowly, okay? It's important to note that the effectiveness of hydroxyurea depends on adherence. If you're not adherent, the patient will not have any clinical response. The clinical response can take up to 6 months. So do not give hydroxyurea this month and expect a dramatic change. For some people, it is like that, but for most people, it's between 3 and 6 months. Some children, some adults don't see an increase in hemoglobin F, and that is because of some genetic factors that are inherent to them, or the MCV does not go up as expected because of underlying iron deficiency or beta thalassemia. This is not an indication for you to stop therapy. As long as they are clinically better and the hemoglobin is going up, don't stop the therapy. Please don't discontinue therapy because of uncomplicated fever or hospitalization. I've seen that happening. A child is hospitalized, people say stop the hydroxyurea. You only stop hydroxyurea in very life-threatening conditions. Okay, a child has liver injury, who is unconscious, you can stop. But for any form of hospitalization, which is not life-threatening, do not stop hydroxyurea. What are our challenges? You're going to find we have formulations of 250 and 500 milligram capsules, but we have overcome that. We know what to do. You get the total dose per week and divide the number of capsules by the total number of days. So for example, if you have a child who is 10 kilograms, they should be taking 10 times 20. That means they should be taking 200 milligrams, but you only have 500 milligram capsules. Multiply that 200 by 7, you get 1,400. Divide the 1,400 by 500, you get about 2.8. So you give that child 3 capsules in a week. You tell them to swallow a capsule on Monday, a capsule on Wednesday, a capsule on Friday. And you keep increasing the number of capsules as the weight increases. Novartis has introduced some squad capsules. They have 1,000 milligrams, they even have 100. We are very happy for that. They're still highly priced. We are trying to talk to them to tell them, look, our patients don't have that kind of money. I hope they will, come down. But for now, the 500 milligram capsule is the cheapest. It's about 600 shillings, the same price as a 250 capsule. So you're better off buying a 500 milligram capsule and doing this the way we are telling you to do. There are no capsule formulations and there are no syrups. Some people in Nacho are telling us they can reconstitute it. That's okay, and it's stable for 3 months. That's fine. But even then, if a child is not able to take it, take the capsule, open it up, put it in water, dissolve it, let the child drink. As long as they drink the whole formulation, that is good. We're actually using that in clinical studies and it's working very well. The other challenge is adherence to dosing. This is brought about by many things. The problem is out of stocking of the drug, but also adolescents tend to really tire. They tend to tire taking many drugs. Children with sickle cell disease take Hydroxyurea, they take PenV, they take folic acid, they take Fancida. Some of you give them even multivitamin. So they have so many drugs they're taking. When they become adolescents, they take almost 3 capsules of Hydroxyurea, so they tire. And so it's important that you actually address the adherence. The big elephant in the room is erratic availability of drugs. Sometimes NMS brings, sometimes they don't bring. And so the patients don't adhere to Hydroxyurea, which is a big problem. Okay. Another challenge that you're going to hear about, especially in males, adolescents, is that they're going to read articles that Hydroxyurea causes reduction in sperm count, that it causes infertility. So some studies suggested that it does reduce the amount of sperm count. However, the reduction in the sperm count is not enough to affect fertility. That's the first thing. Other studies that have been done in pubertal boys actually have not shown an effect on that sperm count. Okay, so we are getting more and more information about the safety even in boys. But also, if you leave sickle cell disease untreated, it does cause infertility on its own, because it does cause priapism and also causes vasocclusion in the testis. And so it does affect a sperm count on its own as a disease. Okay. So we have seen boys and men who have been on Hydroxyurea for more than 20 years actually have children and have normal sperm activity, sperm count. So you should reassure your patients that this is something that we know. Don't say it doesn't happen. It can happen, but it's not sufficient to cause infertility. There are people who have done long-term studies, almost 20 to 30 years, and they have shown that it remains safe. These effects that I'm talking about are long-term. So you have sustained increase in hemoglobin, in MCV, and in HbF. So there's no tolerance. Even if a child is on Hydroxyurea for 20 years, they're still having effect, okay? Their reduction is in the acute reticulocyte count, in the platelet count, and total white cell count, and even the bilirubin levels, even the liver function test start to get to normal. Some of these studies have contradiction that there's no effect on growth, but importantly, there's no risk of development of leukemia. So most people are saying, giving an anti-cancer drug for this child, they will get leukemia. They actually have no effect on leukemia, and there's no effect of development of new DNA mutations. Okay, so Hydroxyurea has no risk of increased additional risk for leukemia. And this is very good information to give to our patients. Okay, it is ideal. We like it because it's a single agent. You give it once and it has very many effects. It's already administered and it's given once daily. It's not like, amoxicillin, which you have to take 3 times in a day. It has multiple effects, okay? Increases hemoglobin F, which is okay. And then also total hemoglobin. It has multiple clinical effects. The treatment goals, it works in all age groups from the age of 9 months up to 100 years. So that is very good. Some drugs, like I shall show you later, don't actually work in certain groups, okay? The side effects are few, the short terms are few, and they are transient, and there are no major long-term toxicity levels, okay? Hydroxyurea has its limitations. Females are planning to conceive or who are pregnant, okay? Also, should not be used in males who want to, trying to get someone pregnant, okay? And sometimes it doesn't have some effect on certain people. You can see that some people in your clinics will be on hydroxyurea, but will not really have any benefit. So those people are there because of some genetic factors. So don't force people to take hydroxyurea if there's no genetic benefit. So quickly, what are other disease modifying it's an amino acid, okay, and it causes production of glutathione, so it allows to reduce oxidative stress in sickle cell disease and also opens up the blood vessels. It's used as a mixed powder at 0.3 grams per dose twice daily, but it's only used for children above 5 years, okay? So if you have a child who has pain despite hydroxyurea, this is a drug and it's available in Uganda, okay? Crizanlizumab is an monoclonal antibody, which is against P-selectin. P-selectin helps platelets and red cells to attach together. So it reduces on that problem of coagulation and also endothelial activation, okay? It's only indicated in people who are above 16 years. So this is not for children below 16 years, and it's only for people who are not responding to hydroxyurea or L-glutamine. It's very expensive. It's about 16,000 to 52,000 US dollars a year. So this is kind of out of our league. Voxelata, there are some trials that are happening in Uganda here, but it's only approved for children above 12 years. It inhibits hemoglobin polymerization, so it's very good for children who have persistently low hemoglobin levels. But it's also very expensive. Its approved dose is 1,500 milligrams daily and costs about 36 million a month. So you can see that hydroxyurea remains the most available and the most cost-effective treatment. Chronic blood transfusion, I can talk about that for stroke prevention, but also when hydroxyurea is not safe, for example, in pregnant mothers, it can be used for 6 months and then you switch to hydroxyurea. What about herbal medication? We don't have enough sufficient data. There's some data that is coming from Nigeria that there's some herbal management of sickle cell anemia. They've published these things, so we cannot ignore them, but we don't have enough. We have not really looked at it enough to be able to recognize or to recommend it. There is a syrup called Jenna on the market that I'm seeing a lot with our sickle cell disease patients. It has some property against anti-sickling, according to what the drug combination that we see. But it has not been cleared by randomized clinical trials. In medicine, for you to get a drug onto the market, you need to give us evidence from a randomized clinical trial. So you give some people Jenna, and you don't give some people Jenna, and then you show us that it's actually safe. So we don't have information, although the active drug, the active ingredient, which is 2,4-hydrobenzoic acid, can actually have some anti-cyclic property, but we don't have any safety data. So I'm going to stop here to allow people to ask questions on hydroxyurea. Those are my email addresses. You can reach me at those and be able to, I'll be happy to take on any questions. Thank you.
Wow, wow, wow. Thank you, Dr. Namazzi, for the wonderful presentation. This looks an explosive attendance. Wonderful that you've made. As you can see, the audience has been good, and a peak attendance of over 376 attendees. This is a wonderful one. Thank you so much for leading us drugs that we use for modifying the sequelae of sickle cell. And I've already mentioned, like you've already mentioned also, that sickle cell is a very big challenge. The Wachabazinga of Busoga is taking this matter very seriously. the ministry has taken this matter quite seriously. So we have a role to play, majority health workers, to make sure that we reduce death and mortality among children with sickle cell. And so we are going to open the microphone. You just raise your hand and I'll pick you. Let me see if I can see some people. You ask questions, but we can't say it enough that we are proud of the work that Dr. Ruth Namazzi and her organization and the university are doing to make sure that we increase a survival of children that have sickle cell. This is not a topic about prevention, but I think Dr. Namazzi will give some remarks on prevention because I think we need to hit this disease from multiple fronts so that we pull down the prevalence of that disease, but also even the prevalence of that trait, which increases the probability of getting the disease. So Rachel,
Yes.
yeah, you open your microphone and ask Dr. Namazzi a question. Then then Mr. Owino, you come through. Then we go to Joel and then Valeria. At least those hands are up. Please go ahead, Rachel.
Thank you so much. Good evening, everyone. Hope I'm audible. Thanks for the presentation, Dr. Namazzi.
Yes.
I have a question for you. I have a client that I'm looking after. She's a non-sickler. She's 26. She reports to be adherent on her hydroxyurea. However, she gets multiple crises every month, especially towards her periods. And her HB is never above 6. We have tried multiple transfusions, but every time she gets to her periods, she gets a painful crisis. So how does hydroxyurea and periods, is there any benefit of hydroxyurea preventing painful periods, or it's not reported anywhere? Thank you. I submit.
Thank you. Yeah, periods have been known to trigger a painful crisis, and those are some of the reproductive complications of the disease. So yes, I want to know what dose that your patient is at. Have we optimized the dose?
She's taking 1 gram.
What is
She's
the
about
weight?
52. 52.
I would want you to escalate it because that is about 20 milligrams per kilo per day. Escalate and see. Escalate, like I've told you, escalate by 5 milligrams per kilo per day, and then see how she does. Okay, and towards the periods, you can actually try to take some preventive measures. You know, she takes painkillers before, hydrate a bit earlier, take some bed rest because periods are known to trigger complications and pain episodes.
Thank you. Thank you so much, Dr. Namazzi, for that response. I go to a man called Owino. Please unmute and address your question to Dr. Ruth.
Sorry, thank you so much. I just needed her to maybe clarify on the what? On the dosage, because most of the patients by this side in Toro, most of our patients are about the very young patients. So there's that part where she spoke about the dosage, calculating the dosage for the children, where you're giving on Monday and Monday, Wednesday. I didn't get that so well. I just need that maybe to re-clarify for me on that, how to do the calculations and something of a sort.
Great. Okay.
Thank you. That is a common scenario you're going to find. So you dose the hydroxy according to the weight. So imagine you have your child, maybe it's 10 kilos, okay? So the dose you are going to start with is 20 milligrams per kilo per day. So you multiply that by 20, you get a dosage of 200 milligrams daily, but you don't have a 200 milligram capsule. So what you do is you multiply the 200 by 7. That's what they should be getting in a week, okay? So 200 times 7 is 1,400. You have a 500 milligram capsule. What you do is divide that 1,400 by 500. You get about 2.8, round it off to 3. So you need to give that child 3 capsules in a week. So you get that total dosage per week. And so you tell them to take a capsule on Monday, take a capsule on Wednesday, take a capsule on Friday. We don't want you to take them to take the capsules all one day because we are fearing toxicity. So the fact that it's rapidly absorbed, we know that it will go down, and then another day like that. So it is actually safe like that. So look at the weight of the child, and then get the total dose per week. Okay. And even when you're escalating, that's what you should be doing until you get a point when they can take every day, or until we get a point when we can get the good formulations.
I just have
Great.
some announcement, Samuel. I'm requesting Mugino Noah to avoid touching your screen because you're making our life hard by drawing things on the screen. Kindly don't touch your screen. Thank you.
Okay. Thank you. Thank you, Dr. Ruth, for that response. I'm going to a lady called Wanyana Valeria. People who have posted in the chat, I'll have a minute to make sure to make aware of the post you made in the chat to Dr. Ruth so that she can also make an attempt. But if she has attempted what you posted in the chat, then we shall not repeat it. So a lady called Wanyana Valeria.
Yes,
Unmute.
thank you. Thank you, Dr. Ruth. For me, I'm a new parent of a sickler who has just been discovered at 6 years.
Yes.
That she was a sickler. But depending on the conditions, for example, the signs, the symptoms, she was not showing. I took her to the hospital because I saw her eyes yellowing and her body a bit yellowing, but she was really okay. Then one of the questions I had in my mind was, if it can be discovered at 5 to 6 months, why wasn't I able to recognize it as early? Okay, recognizing the signs as early as possible. Then another question I have is, when I'm applying the hydroxyurea, at what stage should I start? I'm sorry, I a bit joined late, but maybe I can take the opportunity. At what stage can I? Because they were telling me to join a sickle cell clinic, which I've not yet joined because I'm new. I'm a 1 week mother after being told the news. And another question is the feeding. She's allergic to soya. She's allergic to milk, eggs. So I don't know, will that affect her diet, like her nutrition? I really don't know. Maybe I can have an advice of the different foods that she can replace in case of the other, because she gets allergies when I give her eggs, when I give her milk since childhood. And she didn't breastfeed at the start.
Yeah.
I used to feed her on these other artificials, the nanny opti. So basically, those are my questions.
Okay, Valeria.
Yes, please.
Where do you stay?
I stay in Mukono.
Mukono.
There's a clinic in Mukono.
There's a clinic in, okay. Dr. Bruce, you can go ahead.
There is a clinic in Mukono.
Yes.
So I think there's someone called Wycliffe. We've trained him. It's called Dr. Wycliffe. Name. Someone is, I think, having two. Someone is having two things going.
Aurelia, could you responded to?
The what?
Mute.
Are you mute?
You're muted.
Maybe if possible, doctor, I'm requesting maybe I can know where your place is, your location, so that I can come, because I always treat my kids from Nalfenya.
Nalfenya is excellent. Go and look for Kasibante, who take the best people there. So Nalfenya is also excellent. Me, I work in Mulago National Referral Hospital. You can also come. But the advice is, please take the child to a sickle cell clinic where you will be followed. Start the hydroxyurea. So sickle cell disease is a very interesting disease. It has the same genetic abnormality, but it treats each person differently. We have children who we don't know have sickle cell disease until they are 9 years. And then they present with a stroke, okay? If you look at your child's hemoglobin electrophoresis, you're going to find that their hemoglobin F is a bit high. So that is what has been protecting them. So because of some genetic factors, some people's hemoglobin F remains high. and so they are protected. It's only when it starts to come down at age 6, 7, 8 that you actually start to see symptoms. But for most children, it begins at age 6 months, okay? That is why we want to do newborn screening. Dr. Kasimanti asked me to talk about prevention. Newborn screening. If you had screened your baby at birth, you'd have known this early, okay? And also screening of young people before they get married. If you know your status before you get married, you probably would not have chosen someone who has trait, okay? We can actually stop sickle cell disease because we know how it spreads, okay? It is when someone marries a carrier, that's when they produce a child with sickle cell disease. If you're a carrier and you marry AA, your children will have the likelihood of getting a carrier would be almost half. So it's important that we all know our sickle cell disease status. I can see we're almost 400. If you don't know your status, please, you must do it immediately, because then you stop propagating the gene. So that's the only ways we're going to stop sickle cell disease. So if we can do newborn screening so that we can know early and institute treatment early, then also we don't marry, if you're a carrier, you don't marry a carrier. That is the only way we're going to stop sickle cell disease. But please take your child to a sickle cell clinic. Nalufenya is good. It has a sickle cell clinic. I think nowadays it runs twice. There's a pediatric clinic and also an adult clinic. Also, Mukono, there's a doctor called Wycliffe. He's very passionate. We've trained him. He knows how to manage sickle cell disease. Or if you want, you can come to Mulago. I run my clinic every Tuesday, so we can follow you up. For feeding, a balanced diet. You don't have to eat eggs for protein. So you can give them meat, you can give them fish, you can give them beans, okay, as long as a balanced diet. So every day, make sure they have a protein source. They have vitamin source. They also have a carbohydrate source. Okay, so you can give them portion beans and greens. That's enough. You don't have to give them eggs and milk.
Thank you, Dr. Ruth. This is an interesting presentation. And Dr. Ruth, you've already noticed that people attend your presentations in an explosive way. And I'm going to do really good service to make sure that no one is left out. Valeria, make sure that this child is seen. If you prefer Dr. Ruth, you go to Mulago. And if you prefer to be near where you want to spend a lot of money, you go to the Mukono Clinic, but also Jinja Hospital will welcome you with open hands. I want to move to a gentleman called Mukwaya James. Unmute. Make the question short because we are now getting into the zone of beyond 1 hour. We shall extend by a few minutes.
I think it was Joel.
Yes, thanks
Joel.
very much. Thanks very much, Dr. Ruth, and the moderator for this discussion. I have also a patient who is sickler, and this patient has been sick for the last 11 years. However, from the year of 1 to the year of 10, the sickler was discovered and has been undergoing a medical treatment, folic and malaria and other things, and she has been stable for some good time. However, when I was recommended at Mulago Sickle Cell Clinic to go for Hydroxyurea, the sickle has gone back to monthly crisis and monthly pain. And these days, she's taking this Hydroxyurea, she's taking the folic, she's taking the painkiller, including the trap, the most strongest painkiller, and she's not relieving, going back to its normal. And we have become puzzled at this stage. The question is, what is it? Because without the Hydroxyurea, the trap, and others, would you change the game? Because the folic and the simple Panadol and ibuprofen, we are doing it better. So what is the cause of that? Number 2, when it comes to diet, we have tried to give these children the diet, the proteins you've talked about and other things, but the crisis has continued to come, and they have a lot of pain. They don't want to be touched. They don't want to see anybody. They feel fatigued, and what is that can be known and we can handle? Over to you, doctor. Thank you.
All right, thank you.
Thank you, my brother Mkwaya.
We have had we've had such patients. Actually, I'm looking after one now. Is actually an adult. Somehow they decided to stay with us. Please bring them. Which day do you come? The problem is sometimes you come and see this doctor today, then another one tomorrow. Come.
Yeah, I'm in Nansana.
Yeah, so bring them to Mulago. Bring them. My clinic runs on Tuesday. You come and introduce yourself to the data entrant, the data officer is called Paul. You say you want to see Dr. Ruth. We're going to work it up, okay? Sometimes the dose is
Thank you.
okay, so we can take care and see what is going on. But we have seen this before. It's not only you. About some people first react like that, and then we play around with the dose. We play around with different treatments. We play around with blood transfusion until we get a stable dose for your child. Because when they're getting pain, that means the sickle cell disease is not controlled, and that is a bad thing for them. Okay, we want your child to be happy, even if they have sickle cell disease. So you bring them. We know how to play around with different treatments. We can try L-glutamine. So you bring them and we see them. And this is the importance of you being in a continuity clinic, especially for when you're not responding. Please come, we shall be able to see her.
I'll be there on Tuesday. Thank you.
I wanted to suggest a modification to this meeting, to this presentation, that Dr. Ruth will receive the 6 hands which are up, and then you answer at once, because it gets interesting as time goes, and I never wanted to leave them out. Maybe you can combine their questions and answer them at once. But also somebody has advised that we do not call them sickle cell patients. We need to change name. I saw the message. I think we call them warriors. So if in the interest of a good discussion here, when you are referring to a sickle cell patient, call them warriors. So I'm going to take the hands of Joel, then Evander, Jacqueline, Wycliffe, and Pauline. So I'll start with Joel. Please make the question shorter so that we get all the 6 hands up, all the 5 hands up. Yes. Please, Joel.
Thank you very much, and thank you, Dr. Ruth. My name is Joel, and I work in Kalangale Center 4. I have a sickle cell clinic of more than 100. We started Hydroxyurea in 2022 November, and of recent, this year, we have employed a gazelle to look at the fetal hemoglobin. But there is one thing which has challenged us, that is, I've realized that there are people who started in 2022 and up to now, their fetal hemoglobin has not gone beyond 10%. Now my question is, where do I touch next? Because our monitoring system, like we don't do liver function test, we don't do renal function test, and still we have worries. Even when our biggest dose now is at 23 milligram per kilogram body weight. What do we do?
Great. Thank you so much. Permit me to take the question of Mr. David Evander. Please unmute and let us be quick. Our time is running so fast.
Thank you so much. Good evening to everyone. Now, my question, I have 2 warriors, as you say. One is 11 years, and the girl is 9 years. My question is around the calculations of the weight and the milligrams. The boy is 29 kilograms, and the girl is 24. So good enough, they are in insurance. We get refills for hydroxyurea for 3 months. My problem is now the calculation, because I've been giving them every evening. Each one takes a capsule, 500 milligrams every day. I don't know whether it is on track or I am messing up with their liver. That's my question. Thank you.
Okay. Thank you so very much. Permit me to go to a lady. Permit me to go to a lady called Jacqueline. Please go ahead and address Dr. Ruth.
Thank you, and good evening, everyone. I happen to be Dr. Ruth's student for my PhD on sickle cell disease. My question is around pregnancy. So we know that before conception, you stop 3 months, but now for the benefit of the mother during lactation, so since the baby starts at 9 months, when should the mother resume in case they were on sickle cell? I've tried to look at literature. I mean, in case the mother was on hydroxyurea prior to conception, it was stopped, and now she has delivered. And does it cross the breast milk? So that we're able to know when to start these mothers back on hydroxyurea. Thank you.
Welcome. Okay, thank you. There is a gentleman called Wycliffe. Go ahead and address Dr. Ruth. Wycliffe, have you dropped off? Okay. Pauline, unmute.
Hello?
Okay, yes.
Sam.
Isinga Wycliffe, nsaji sokulaba.
This is Wycliffe Mukono General Hospital. I
Yes.
welcome that mother who has got a newly diagnosed child. I'm available every Tuesday and every Thursday, full time at the hospital. So she's welcome any day, but our clinic runs on a Thursday. My question goes to doctor. It's about those warriors who are showing like signs of resistance, who are not responding on hydroxyurea, even as we escalate to the maximum tolerable doses. Is L-glutamine the solution? Can we try that one as an alternative for those who are failing? Then another thing, there is a mother who continued with hydroxyurea until she gave birth and she had no problem. Now I'm confused. What should I tell her? Because she came back with a second pregnancy and she told me that last time I continued with my medicine and I delivered my child well. Thank you.
Great. This is interesting. And you know, I don't know, Dr. Ruth, you need to do a clinical trial again on or you need to an investigator to try out this drug here among adults who pregnant, probably that will give us more answers. Permit me to end her. Ongodia, okay, I've seen your hand up. I won't leave it, but let me go to Pauline. Pauline Namwebe. Namwebe Pauline. I think Namwebe is not there. Let me take Ongodia's hand. Ongodia. Emmanuel Ongodia.
I'm here, please. Pauline, I'm here.
Okay, please go ahead.
I beg to steal you.
I just wanted to have a pardon on the treatment of children below 6 months or 9, that powdered drug the doctor was talking about. And another thing, what if the person takes that hydroxyurea when he's pregnant? What is next? And you get to know the pregnancy after that client taking that drug.
Good question. Yes,
and the minimum dose for hydroxyurea, and maximum.
Okay. I think the questions that involve dosing, Dr. Ruth is going to post her presentation. You can download it. She has explained a lot about the dosing. I saw it in the slides. I think we can pick additional information from there. But also there are national guidelines on management of sickle cell. I think they have a part on dosing. But Dr. Ruth will come through and answer those questions. But let me listen to Emmanuel Ongodia.
Yeah, thank you so much again. I had recently an interaction with a child at 6 years of age. He's a male. This child had been on hydroxyurea for some time, but the child doesn't receive the care from here, but because of the worsening of the condition, came to our hospital for care. When we had a workup of the child had elevated liver enzymes. All the liver enzymes were elevated, but we went ahead and even did a hepatitis B test, and the hepatitis B test was positive. So we did the hepatitis B viral load, and the target was not detected. So we thought the elevated liver enzymes were due to hydroxyurea. We advised to first stop the hydroxyurea, and like after 1 month, when we did the repeat test, they were normalizing, like almost like maybe only 2 above the upper limit. So my question to doctor is, when will we consider to reinitiate this child back to hydroxyurea?
Great. And let me end with Brian Sande. Make it short. I'll try my level best to, I have tried to peruse through the chat, and in there are just praises and And thanks to Dr. Ruth for the wonderful presentation. For the questions regarding dosing, you are going to pick the answers from her presentation. But as you can see also, she has left her mails. You can drop her a mail and I know she'll answer you. Kindly, Brian Sandy, unmute, address Dr. Ruth as I check which questions are peculiar within the chat.
Yes, thank you, Dr. Ruth, for the wonderful presentation. Mine is to know if there is any extra benefit of doing combination therapy. For example, can you do a combination of hydroxyurea with L-glutamine? Yes, if that is possible, is there any advantage that it can add to, especially those who have resistant cases? Thank you so much.
Welcome. Yes, now back to Dr. Ruth to try to respond to what our audience has asked. Yes, go ahead.
Okay, thank you. These are very interesting questions. I'll try to answer all of them. So from Brian Sunday, yes, there's benefit, especially for those who are not responding to hydroxyurea. You can combine L-glutamine with hydroxyurea because they have different modes of working. Some people will switch them completely to other modalities. There's a bit of, some people can afford Voxleta. It's still in trial, it's not yet approved in Uganda for use, but for experimental patients, we can do that. Also, we also tend to combine hydroxyurea and blood transfusion, okay? So we give PRN, or what we call a short-term blood transfusion regimen as we are building up the hydroxyurea. So there are ways of combining benefits, especially for those that are not working on monotherapy of hydroxyurea. Hydroxyurea for long and toxicity. So you reinitiate when the liver function has come to normal. Like I said, sometimes it never goes back to normal. For as long as it is not more than twice the upper limit, look at the upper limit of your lab, you can actually reinitiate, but reinitiate at a lower dose, okay? Reduce the dose by 5 milligrams per kilo per day, and then escalate above slowly, okay? What is the maximum? What is the minimum? There's no minimum. Okay, some studies in Nigeria think that you can even go as low as 10. Okay, the maximum is 35 milligrams per kilo per day. Above that, it's going to become toxic. Above that, you're treating cancer, okay? But for children, we start the most effective dose, or starting dose is 20 milligrams per kilo per day, and then escalate. And then for adults, it's 15, because why 15 for adults? They are more likely to get toxicities, okay? Wycliffe, not responding to hydroxyurea, the pregnant woman, there are many who are taking hydroxyurea while pregnant. The issue is that you will not see anything wrong to the baby, but the long-term effect. Remember, this is a drug that suppresses DNA synthesis. So this is a child who is growing. The fetus is the most period of growth. So we don't want to be giving a drug that can affect, the fetus at that level. So we don't know. So even if the child looks normal now, praise God, but we don't know the long-term effect. So we would not advise. If you have a pregnant mother who is taking hydroxyurea, stop the hydroxyurea, okay? There are other things you can do. You can give them a short-term blood transfusion for them. Pregnancy is not for life. It is for 9 months, isn't it? After 9 months, the pregnancy actually goes away. So Jacqueline, the benefit after 9 months, after they have delivered, you can restart hydroxyurea. Breast milk, but it was very little. It was not enough to cause any harm to the baby. So you can restart when they have delivered to save them. And during pregnancy, give them some blood transfusion as is needed. The guidelines are not very clear, but expert opinion suggests maintaining the hemoglobin level during pregnancy at about 7, so that you can give blood as is needed. Okay. David, yours is a dosing issue. You can look into the presentation, but if you multiply 29 by 20, you get about 580. Multiply that by 7, you get almost 3,500. So divide that by 500, you realize that you're going to need more than 7 capsules. Okay, so for the child who is 29, you might you're giving a lower dose. They would need an extra capsule on Sunday. So I'd suggest that you give them Monday to Saturday, 1 capsule, then on Sunday, give them 2 capsules. But okay, Kalangala, that's a very interesting observation. Thank you for doing the gazelle. I've heard very good things about the Kalangala sickle cell clinic. We should be coming to see you sometime. People whose hemoglobin F will not go up because of the genetic factors. The reason why hemoglobin changes from F to F to A is all genetically controlled. So there's some people who have genetic, I don't want to call them mutations, but factors that stop them from switching or increasing their hemoglobin F production. So they remain at 10%, but as long as they have a clinical response, do not stop the hydroxyurea. The hydroxyurea is actually working. Food, okay, so there's someone who has a child who has sickle cell disease, was well until 10 years. They were not on hydroxyurea, they were well, okay? And then inside hydroxyurea, something happened. Please bring the child, okay? Even if a child is sickle cell disease, looks well. Sickle cell disease is a progressive disease. Slowly, it is destroying the organs, okay? Even if you're a parent, that's why you see sometimes your child is okay until 10 years and then they have a stroke, because progressively, it is actually destroying some of the body organs. So bring, and we understand what is going on. We know what to do. Again, we play around with different treatments. We have some people now who are good at counseling. We understand them, okay? So please bring them for care. We will be able to take care of them. I think I have answered all the questions, Mr. Kasibante.
Thank you so much, Dr. Ruth. The chat has been quite busy. I can't imagine this. Quite busy, but please, I request you, in the name of God, to drop Dr. Namazzi a mail. I think she will, she will answer you. For those who think that their questions have not been well attempted in this short presentation and the short period we have for this session, kindly drop Dr. Namazzi a mail. She will reply to you. I am going, at the close of this meeting, I want to request Dr. Powell to address us, but before he comes up, I thank you personally and on behalf of this good audience, Dr. Namazzi, for presenting, for giving a wonderful presentation. You've been a wonderful presenter on this forum for quite a number of times. And we also, Ginger Hospital is proud of you for the work you're doing in terms of research and all the leadership you're giving to the organizations where you work. And so without saying much, somebody asked about testing for sickle cell. And I think, Dr. Ruth, you've not attempted that, but in the program.
Sorry, what was the question?
The question was in the chat about how to test sickle cell. I think you answer that. But there is a lot of work in the program. The ministry is trying as much as possible to open as many sickle cell clinics across the country. And there is a newborn screening program. Please, there is a hub system. If you have a child with sickle cell, take them to a health center or regional hospital, general hospital. They take off a DBS and you'll get your results back. And Busoga Health Forum, for the interest of Busoga, is trying as much as possible to create a general database and a software that can ensure all patients who come and get their blood taken off, they can receive results back within their SMS. It is something that we are pursuing, and in the fullness of time, we shall make sure that every person in Busoga can access a test and they can receive their results. But recently, Busoga Health Forum bought a gazelle for the regional hospital to ensure that there is access to this to the testing, because as Dr. Ruth has said, testing and screening is very important, especially in early detection, but also as a preventive measure in terms of somebody knowing their status. I can't say much. Dr. Ruth, come up and answer the question on how to test so that people can have a 360 outlook on this in this presentation. And after you, Dr. Kaweru will address us last and thank you in a special way. Thank you.
So thank you for the question. It's important that we test. It's the only way we can prevent. So there are several modalities of testing. One of them, Dr. Mr. Kasibante has told us. the DBS, the hub. Okay, so they put for newborn screening, you know, they put the blood on the child on the DBS and then take it to CPHL and then they test for sickle cell disease. But also you can test using point of care, the Gazelle. Okay, you do it like within 10 minutes you have the results. So we're actually advocating for that, such that wherever you are, wherever you have a clinic, you can actually have a sickle cell disease test done. You can also do HB electrophoresis. That's it's a bit more expensive, but usually the big hospitals actually have those machines and you can actually do that testing. So it's the ministry is trying as much as possible to make this available, such that wherever you are, wherever you have a child born, if you have a center where children are born, you should also have a capacity to test for sickle cell disease, such that as a child is going away from immunization, you actually know sickle cell disease status, and then we can link you to care. Thank you.
Dr. Kabweru, you're welcome to the podium.
Thank you very much. By the way, I want just to inform the listeners of Busoga Health Forum that Dr. Namazzi is the reigning champion as the best presenter on this forum 2023. And Dr. Peter must have delivered your award. If not so, please pick up from Dr. Peter Waiswa. He still has it, being the board chair. So
I got it. Thank you.
You got it, and thank you very much. And I want to announce today that actually you are still, you are like a Real Madrid. You are still beating people at 383. So I want to call upon the other presenters that you have a reigning champion and is not about to stop today. Otherwise, with a lot said, thank you very much. And I want to say that I have a lot of vested interest with surgical complications that actually happen in C-class. And I think I should team up with you one day and we do some follow-up and we see how best we can save and deliver that service, because they tend to get a lot of surgical problems, including gallstones, tropical ulcers, priapism, and a number of so many things, and acute chest syndrome, which actually claims a number of lives, and I've been consulted several times to manage some of those patients. And being a specialist in Mlago, I think I should visit you and we do something. Sometimes I get a lot of pleural effusion in the chest and we tap it out. But when the acute chest syndrome comes, sometimes it follows pneumonias and it's very difficult to save them. So we have lost so many colleagues' children, and it's quite touching. And I want to say that actually, I don't think there's any family in Uganda that is not affected by sickle cell. If not affected, then it is really very lucky, but I don't think so, because this disease, disorder is very common. But we should remember that sometimes when it comes to love issues, so many times people don't do the right things and they should have tested. But sometimes by the time they test, they have 1 or 2, 3 children, and it is very difficult for them to let apart. But thank you very much, Dr. Namazzi, for that clear presentation. And please, when we call upon you, please come back and educate the masses. So many people have attended 382, but we are going to multiply by the number of the clinics people are running. So we have had so many attendees on behalf of so many patients. And I was very impressed by the patients, the parents actually who on call, and they asked very key points and they ask for help. Sometimes when we make these presentations, I think sooner or later we shall be assessing the impact. So it seems the impact is really moving to the direction that we want as our strategy. We want to educate the masses. So we want the professionals to educate the masses, and we send the service closer to the wananchi, wherever they are. Thank you very much, Dr. Namazzi, and on behalf of Busoga Health Forum, I want to present to you this certificate of appreciation. That thank you very much. May God bless you always, and thank you for being a crowd puller. You should teach me also, and I pull crowds, and then we see forward. But it's quite very interesting always to have you. And thank you for the service you are delivering to my region. I love that region as I love the entire world. but those are the people who made me what I am. And really, I can't pay back, but I'm always very happy when people speak to the masses. And we want to thank you. Please come back again. And on behalf of Busoga Health Forum, Mr. Kasibante Samuel, thank you for, first of all, doing a lot of work. And without diagnosis, we cannot know what we are suffering from. So this Mr. Kasibante here is very key in the clinical care, because he's the one who gives us the results that I've done these tests, and now I confirm or I disconfirm that I say that you're not having this. So, Mr. Kasibante, thank you very much. And for your good moderation this evening, we really appreciate, and we say thank you very much as part of Busoga Health Forum. May God bless you all. And to our dear listeners, please always tune in on every Friday and you learn, because I was in Narambai Primary School, and we used to say power is knowledge. When you have knowledge, you have the power to speak. So when you're educated here, you're going to become a better parent by being the first doctor to your child before you visit Dr. Namazzi and so many of her counterparts here. We are very grateful, and we want to wish you a good evening and a good weekend. May God bless you all, for God and my country. Good evening and bye-bye.
Bye-bye. Good evening, everyone. I wish you well. And remember to pass through the presentation Dr. shared so that you can get more knowledge. Thank you so much, Dr. Wilberforce. Thank you.
Thank you so much, members, for attending our webinar. Thank you, Dr. Namazzi. Thank you, Samuel, for this wonderful moderation. And Dr. Namazzi, we shall be glad it has not ended because we have left our audience still.
Thank you.
Yeah.
Thank you. You just have to ask, and we will be happy to come back.
Okay.
You're welcome, Dr. Namazzi and company.
Yes.
Okay, members, you are free to depart at the end time. Let's meet next Friday at the same time.
Thank you very much, Benjamin. Thank you very much, and welcome back from Owachabazinga. Afumvuwe.
Yeah, thank you, members. Today has been the coronation of our Chabazinga. It is 10 years that is reigning and serving the people of Busoga. To Eddie Abalangira, thank you so much. Professor Peter is a brother, but I think he has left. He will tell us more. He's one of the Balangira. He would have been telling us more about that. But thank you, members.
Yes, most welcome.